So I have an order for Mrs. Bobby NG to administer 100 mLs of a house supplement via an NG tube using the open system using a syringe. So I'm going to knock on the door. I will open the door and I will perform aided. Watch for safety, use standard precautions, privacy, and the correct body mechanics. I'm going to perform hand hygiene, and I will identify my patient using two identifiers. I will check her wristband, and I will ask her to tell me her name and date of birth. Okay, very good. And now I will check to make sure. I'm going to check my patient's chart to make sure that the tube has been confirmed through an X-ray. So if the tube is placed in the stomach, I will check in her orders. So I checked and it has been confirmed. There are other measures that I can take, and I will do that in a little bit. So first, I'm going to lower the rail and make sure that my patient is in a 30 to 45 degree angle. I am going to place a drape underneath the tube on my patient, a linen saver drape. Then I will perform hand hygiene. I'm going to make sure that I have the correct feeding, and I will check the expiration date. I'm going to check what type of feeding it is, the rate of infusion, which is gravity on this case, and also the frequency to see how often I'm going to be giving her. For this case, it's every 4 hours. I'm going to check expiration date, and I'm going to shake it and make sure that this feeding is at room temperature. If it was a continuous feeding, then I will make sure that it's cold. I mean, not cold, cool, but not cold. Sorry about that. And now I will don clean gloves, and I'm gonna use some bedside methods to confirm the placement of the tube. One of the methods is to ask my patient to speak. And how are you doing, Mrs. Bobby? Okay, so she's fine. And then another method is to aspirate the contents of the stomach and check the consistency, the color, and also the pH. It needs to be between 1 and 5.5, and the color needs to be either green, white, or tan. So I will reinstall that in the patient. Another method is to measure the tube from the nose to the port, and another method is to insert 5 to 20 mLs of air and auscultate with my stethoscope for a whooshing sound. And now that I've checked using the bedside methods, I am going to start the feeding. I will remove the plunger from my feeding tube, and I will connect it to my tubing, and I will flush it with 30 mLs of water. I will clamp the end of the tube, and then I will make sure that I have my 100 mLs of food, and I will start feeding my patient. I will not fill the syringe all the way to the top, and then I'm going to unclamp it and let it flow slowly. If it's flowing too slow, then I could lift it up, or if it's flowing too fast, I will lower it, but I will never go above 18 inches of the insertion part. We'll then clamp it again and not let it get empty, and then I will put the next feeding in there. And when all the 100 mLs are done, I will clamp it. I will put some water, 50 mLs of water to flush it. And then I will disconnect the syringe, and I will make sure that I cap the feeding tube, and then I will take this out. I will encourage my patient to gargle, and I will keep the bed elevated 30 to 45 degree angle for 1 hour after. Then I will provide also frequent oral hygiene and make sure that I do the last part of aided. Watch for safety, put the rail up, and make sure that my patient is in a comfortable position and the car light and water is within reach. I will remove my gloves, perform hand hygiene, and document. For Other methods are the open system with a feeding bag. I will fill a disposable bag with a 4 to 6 hour supply of formula. I will prime the tubing and then label the bag with the date and the time and the formula type and rate, and then say with big letters, warning for enteral use only, not for IV pump. And then I will make sure that the connectors are not compatible, the feeding connectors with an IV pump. They should not be compatible. They should not be able to mix or get connect. Also, then I will hang the bag in the connector and make sure that I set the rate of the infusion, and then unclap the pole to begin. I will set the correct infusion rate, and then when I'm done feeding her, I will turn off the pump. I will clamp the feeding tube, flush the prescribed amount of water, and cap the tube again, and leave my patient again in the 30 to 45-degree angle after the feeding, and then provide oral hygiene and gargling. For a closed system, I will prepare my equipment, and I will attach the admin tubing to the bottle. I will prime the tubing. I will hang it on the IV pole, and I will verify the placement using my 3 ways: either aspirate, speak, and measure from the nose to the connector. I will clamp the end of the tube, and if the connector is needed, I will connect the feeding tube first, then attach it to the admin tubing. If no connector is needed, attach the 2 tubings. I will trace the tubing from the bag back to the patient. I will begin the infusion by opening the roller clamp on the tubing and regulating the flow. I'll turn on the infusion pump and set the rate and volume of to be infused. To end it, I will turn off the pump or the roller clamp. I will disconnect the tubes, and I will flush the feeding tube with the prescribed amount of water. For subsequent feedings, I will have to check the residual in the stomach. So when checking for the residual, I will measure it, and if it's more than 250 mLs, then and if my patient doesn't have any abdominal pain or abdominal distension, then I will continue the feeding and come back and check in 1 hour. If after 1 hour the residual was still 250 mLs, then I will stop the infusion and I will wait 4 hours. And then if after 4 hours I check on him and the residual it's still over 250, then I will notify a healthcare professional. If the residual was less than 250, then I will restart the infusion at 50% of the original rate. For continuous feedings, I will make sure that the tube is getting flushed every 4 to 6 hours with the prescribed amount of water. For jejunostomies, I will not check for residual, and also when I'm checking the location of the tube, I am not going to insert any air in the jejunostomy tube, but I will check the pH with a pH strip. For gastrostomy and G-buttons, I'm going to make sure that I'm washing the insertion site with soap and water using a pre-cut small gauze, and this is to prevent bacterial growth and infection in the site. For a cough tracheostomy, I will inflate the cough for the feeding and then leave the cough inflated after the feeding at least 15 minutes, and this is to prevent aspiration.